Hi, I'm Ann Robinson, and we're here at the NACCHO Annual 2013 Conference in Dallas, Texas. And in just a moment, we'll be here to talk about a regional community health assessment effort. Hi, welcome back, and I am here today with Ann and Cassie, and they're here from Michigan. How are you guys doing today?
We're doing great.
Thank you.
Welcome, and thank you for joining us. Why don't you guys introduce yourselves and tell us where you're from and what brought you here to the conference?
My name's Ann Barna, and I'm the health analyst at the Barry-Eaton District Health Department, and we're based in Charlotte and Hastings, Michigan, which is near the capital area of Michigan. And we're here today to talk about the project that we did called Healthy Capital Counties, which was a multi-county, multi-health department, multi-hospital community health needs assessment project.
Hi, my name is Cassandre, Larrieux, but everybody calls me Cassie. It's easier. I'm the health analyst for Ingham County Health Department, and my capital city is in Lansing, Michigan, which is in Ingham County, and I am one of the other three analysts who are involved in the Healthy Capital Counties project.
Well, thank you guys for coming. As we were talking earlier, counties and hospital systems are charged this day to come up with a health assessment, but you guys decided to do this a little different in your area. Why was that, and what did that structure look like?
Well, people in our community in Eaton, Ingham, and Clinton counties, even though each of them have different health departments, they all see themselves as part of the capital area. And we have the city of Lansing, which is really located in the middle of those three counties. So we felt like when we started looking at the health of those communities that looking at the three counties as a whole and then breaking the data out in a slightly different way based on rural versus suburban versus urban, regardless of county boundary, was really going to be most interesting to people in our communities.
And really what's going on is our community doesn't necessarily see county boundaries. For example, I live in Lansing, I shop, I have friends in Eaton County, in Delta Township, which I could walk to. I have friends in DeWitt, which is in Clinton County, and we don't necessarily, when we interact day to day, the community doesn't necessarily see those boundaries. They just drive past them and go about their business. They work and they play and they interact in all three counties. And it just didn't make sense for us to say that, basically when you get to Waverly Road, that's the end of Ingham County, and that's where we're going to stop the assessment.
So doing a health assessment is not always the easiest task, but then you were bringing in three separate counties into that. So how did you go about engaging those partners and to start this process along?
I think one of the really benefits of our work and how this happened is that we worked it together. We have a regional behavioral risk factor and social capital survey, and the three counties have been doing that for years. And so we already had a working relationship, and we were comfortable to take on a bigger, much more involved process together because we had that foundation.
The other key thing for us was that we shared the work amongst each of the health departments. In the past, one of the health departments might have taken on the work on behalf of the other two counties. And we felt like with this project that wouldn't work so well because we really needed people who knew the people inside each of those counties and inside each of those communities to have a meaningful community engagement process. And so that's why we had myself, Cassie, Ross Pope from the Michigan District Health Department all worked on that project, and we shared the staffing and we shared the revenue that we got to conduct the project.
Yeah, and also some of the partners that we were trying to engage also are regional players, not county players. And so if we were going to bring them in and have this be something authentic and something that they can use, it had to be regional.
particularly true for our hospitals. We have 2 major hospital systems, and they serve the 3 counties primarily.
So why is public health poised to bring all those entities together? You just mentioned the hospitals, and I know hospitals now, this is a newer task for them to do the health assessment, but why do you think public health is in the position to pull these partners together?
Well, I think public health has always been viewed as a neutral convener, and that way we can sort of bring the various parties together and have that relationship and have that trust. One of the things that my boss is always fond of saying is that it's all about relationships. And we had relationships with the individual entities which were, amicable, and therefore for us to bring everybody together was the next logical step.
Mm-hmm. Especially when you have big hospital systems that really are competitors with each other. The health department is definitely the neutral body. And then also for health assessment purposes, population health is a new thing for hospitals to think about. And they call it population health. We're like, that's just another name for public health. So that was really a good fit for us, I think.
So you did all of this work. What results or recommendations came out of your health assessment?
Well, we're working right now on finalizing our community health improvement plan. So we had the community health assessment first. We had an engagement process with the community, and then we've been forming our community health improvement plan. That's been the most challenging part, I think, so far, is trying to decide how are we going to actually implement things that support the broad interests of the community. So we have 5 strategic priority areas, and how are we going to make that happen through the 3 counties. So in my mind, at least the immediate benefits that we have are, enhanced relationships with our hospital partners, especially enhanced relationships with each other. And then we also have built quite a bit of excitement in the community around making improvements to address health. We didn't really have a particular movement focused just on health in our community, but this has really, I think, enhanced that effort.
You want to know something? One of the things I found out, and that was interesting about this project, is that to do the assessment collaboratively made great sense. However, when we get down to brass taxes and things that have to get done, that is very local, and so what we are trying to do is to galvanize our local communities, because you're much more likely to get buy-in and to get the stakeholders to work within their own community than for them to see, unless they are a regional player, to see the whole region. If I'm, for example, the city planner of Mason, I want to do things in Mason. And we encourage that. If Mason can do something, that's great. They will do what works for them. In St. John, they might want to pick a different part of the strategic priorities, a different part of the assessment, and focus on that. And we don't want to stifle anybody or constrain what it is that they feel that they want to do. I think the way that we designed the assessment is really, there is a part for everybody. There is a part for the business community, there's a part for healthcare, there's a part for the community, there's a part for public health. And I think we designed it in such a way that everybody really could look at what we did and look at the community health improvement plan and really see a place for them.
And really you're coming centrally back to the regional goal and objectives of the results of your assessment that you conducted. So really, they don't know it, but they're all really feeding into that larger body.
Right. We've had one hospital system that that's a small local hospital, and they have decided that to organize their implementation plan around the priority areas identified in the community health assessment, which is really, you know, which is exactly what the point of it was, right? And they actually partnered with their local school district in their local town to implement a Safe Routes to School program. So they've been partnering with them, and we've been partnering also with the school district to get some grant funds for sidewalks to be built along the sides of roads that don't have them, because that was a real need for them. And they saw that safety was one of the priority areas, and they said, well, what about safety and child health is important in our local town? And that was important. So we're really proud of them for, you know, connecting the dots like that, and then, you know, being willing to say, okay, what's most important here in our community? We know what the priority areas are for the region, but what's most important here, and finding a project that they can really work together with partners in the community on.
We're so very pleased. That's exactly what we wanted. You know, hospitals are increasingly realizing that in order to do everything that they are now required to do and to really move the needle and impact population health, they have to think beyond their hospital buildings. And our hospital partners are really at the forefront, really thinking beyond the hospital building, out into the community, looking at what it is that they can do to lend their support. And sometimes, initially when you think about support, the first thing that comes up is monetary, but a lot of what is required is not necessarily monetary. Sometimes it's just influence. Sometimes it's you being there and, you know, using the clout that you have to leverage resources from other places. It doesn't necessarily have to cost you anything. And that's one of the beauty about doing this work and doing it collaboratively.
Yes, it is. And it's really, you know, again, I just commend you guys for bringing these partners to the table and the successes that you have. So what would be recommendations that you would have for a regional or local health departments that knew that they needed to conduct a health assessment? What would be one recommendation that you would make to them based on your best practices and what your lessons learned through the process?
Well, I think one of the things is to really take stock and do some sort of, you know, asset mapping of what is it that you have, what is it that you need, and who can help you do that. You know, the capacity at the various institutions and even at the various local health departments are different. And the way that, you know, the reason why this worked out so beautifully is we could look to the other counties, could see what it is that we did not have that we needed, and we engaged in a partnership which was mutually beneficial. You know, I mean, one of the examples is the way that we broke out the counties. One of the things that I am always trying to work on is how to get sub-county data, because there's a lot of things that are available at the county level. However, most counties are not homogeneous. You've got urban areas, you've got rural areas, you've got suburban areas, you have small towns. And to say that, you know, the diabetes prevalence is X and it be X'd for everybody and that be their, is wrong. And so how do we do this? How do we get closer to what's actually going on? Most times we're prevented from doing that because for example, a small city in my area is Leslie. And if I wanted to tell them, for example, what was their infant mortality ratio, there is so few events that happen that I could not say what their rate was or give any kind of statistics without violating privacy and confidentiality. And so one of the things that we did, and this was actually Anne's idea, is you want to know something. You know, people in small towns, you know, in our area, for the most part, they're more similar than they are different. And so, you know, she came up and said, look, why don't we just break out the counties and then resort like areas together? So, you know, she came up with the idea, and me with my background in, you know, epidemiology and biostatistics, I was able to figure out how to make that happen.
Yeah, I mean, that was really, for us, that was the key. You know, one of the things that we're here to talk about in our session is health equity and how to incorporate that in. And I really feel like displaying the data in the way that makes sense to people who actually live there is one of the keys to trying to address health equity. And, you know, I really think the geographical, when people look at it, it means a lot more to them than just seeing, you know, the rates in each of the 3 counties. Because even if we had done that, it would have been fine, but it really wouldn't have given the richness of the story of really what's going on locally in small towns and rural areas, and even to a large extent in the urban areas as well, because we had urban areas that had very low income areas and very high income areas, and you know, the health outcomes for those 2 different places or those different areas were very, very different from each other. So it's important to acknowledge that not everyone who lives in the urban area has horrible health. Some of them have great health. So,
I mean, it's, you know, in public health, what you have, you work with what you have. And if you have county level data, then you use what you have. But if you have the opportunity to do a little bit better than that, to dice it a little bit finer, why not? You know, if you have, you know, the capacity to figure out how to do that, and to do that in a way that is scientifically sound, then by all means. You know, it would have been a disservice for, you know, for the idea to come up and said, nah, you know, either it's too hard or nobody's done it before, and it's, you know, it's not going to work. You know, figure it out. It took quite a bit of effort, but it was worth it.
And that's where, you know, you couldn't do that sort of analysis with the single county, the size of the counties that we have. So that's where we had to, you really have to start sticking counties together. But, you know, I guess my other piece of advice for folks is when they're considering how they're going to do the community health improvement plan, I think it's real easy because we can get our minds around the real tangible steps of a community health assessment. Start as early as you can, trying to transition people from thinking about that to thinking about, okay, well, if that's, you know, how are we going to do implementation? How are we going to, who's going to do what? How are we, you know, how often are we going to get together to monitor and evaluate? And that's really what our focus is right now for our project, is getting ready for FAB accreditation, is trying to figure out a system for us regionally to figure out how are we going to monitor and evaluate the community health improvement plan over time, and then have that feedback right back into our community health assessment efforts in the future.
Another thing that I would like to suggest to counties who are thinking about doing this, and this was very key for us. You know, our counties are very different. Mine is the largest county, and traditionally what has happened in the past is we kind of try to speak for everybody, and that's not something that necessarily goes very well. I mean, you know, we've done regional things, you know, in the past, and you know, despite our best effort, it becomes Ingham County and then everybody, and that's really was very much detrimental. It, you know, disengaged really the other counties. And one of the things that we took some steps to do is, for example, meetings. We rotated the locations of the meetings. We had meetings in every county, not in Lansing because it's centrally located and everybody usually goes there. Even something as little as rotating the meetings so that everybody feels some ownership to the process, and it's not just, you know, again, here's the big county and then there's, you know, that was so critical, and it was so little. I didn't think that it would be that meaningful, but it really was that meaningful. I mean, this really needed to be shared work. It needed to be really divided by everybody, not, you know, the big county feeling that we have to do all the heavy lifting, because we don't.
You guys, thank you so much for coming here and sharing your story, and so many lessons learned and great successes. And look forward to hearing what your next step is, and hopefully next year when you come to the conference, we can hear what successes came out of all your work. If people wanted to get a hold of you or find more information about your departments and this plan, where would they find you?
We actually have a website for the project. It's www.healthycapitalcounties.org. And then, of course, each of us have our own health department websites. Mine is barryeatonhealth.org. What's yours? Ingham.org?
I think it's hd.ingham.org.
But you know, we really welcome people contacting us through our website at healthycapitalcounties.org to really share some ideas. And oh, the other thing is, we were a NACCHO. I forgot to mention this. We were a NACCHO demonstration site. So our materials are loaded on the NACCHO.org/CHA-CHIP resources website. So you can find a lot of what we've done and a lot of what the other funded demonstration sites did as well.
Well, thank you guys again, and congratulations, and what a great model for people to learn from. And this is Ann Robinson at the NACCHO Annual 2013 Conference in Dallas, Texas.